Good morning. We'll have a discussion about the mandibular nerve block. Mandibular nerve block. So before going into the topic, I have a few slides regarding the syringe. So one should know the parts of the syringe, and this is a very basic topic. I hope everyone knows this topic right from the first year. So to refresh that, we'll start with the parts of the syringe. Syringe as a plunger, a barrel flange, barrel, sleeve, seal, and the lute lock. There are various types of a syringe and it can be used in a various purposes. So we'll see the types of syringe one by one and for what the syringe, that type of syringe has been used. So this is the one picture which shows that there are various sizes of the syringe which includes 60 cc, so 30 cc, 10 cc, 5 cc, and then even a syringe, a tubercle syringe and the insulin syringe with a needle. I hope everyone has seen these types of the syringe in their regular OPs. So this is the type. The types are there are. So this is a picture which shows that the lure lock type tip, and this is a picture shows a slip tip, and this is an eccentric tip, and this is a catheter tip. So this lure lock, where it is used, it is generally used for injecting requiring a secure connection of the syringe to the another devices. Most commonly used whenever you are going to do an aspiration. So that's such condition. So that against one place you have to place a syringe. So in such condition, lure lock is used. The tip is threaded for a locking fit and it's compatible with a variety of needles, catheter, and other devices. Coming to the lure slip tip, a friction fit connection that requires a clinician to insert the tip of the syringe into the needle up or other lure connection in a push and twist manner. This will ensure a connection that is less likely to detach. A simple sliding the attaching device onto the syringe tip may not ensure a secure fitting. Coming to the eccentric lure slip tip, allows for work requiring closer proximity to the skin, generally used for many punctures and aspiration of the fluids. A catheter tip, which is used for flushing catheters, gastrostomy tubes, and other devices. So insert a catheter tip securely into the catheter or gastrostomy tube. So these are the varieties of these types of these syringes. Sometimes you might get a questions based on the what are all the types of the syringes are available and which syringe is used for the what purpose. So you should know it. So coming to the main hero of the topic is a mandibular nerve. As everyone knows, it's a branch of trigeminal nerve. It's the largest branches of trigeminal nerve. And this nerve comes out through the foramen ovate. So this is the main point in the case of anatomy of the mandibular nerve. This picture shows the course of mandibular nerve. I hope you people have read this in anatomy itself. So I'm not going in detail about the anatomy of mandibular nerve and its branches. Coming into the nerve block technique. So what are all the nerve blocks techniques available? In case of a mandible, we have an intraoral techniques and an extraoral techniques. So this intraoral technique, it includes classical inferior alveolar nerve block, which includes closed mouth approach, mandibular nerve block, lingual nerve block, buccinata nerve block, mental nerve block, incisor nerve block, a block of the terminal branches, and a local infiltration. Coming into the extra-oral technique, the name itself states that you are going to insert the needle extra-orally, not inside the oral cavity, which includes a mandibular nerve block, mental incisor nerve block, and local infiltration. This is the flow chart which shows the what are the intraoral techniques and what are all the extraoral techniques. I'm not going in detail about the intraoral techniques in detail. But we'll have a small introduction about it each because sometimes if you get a question, so that will be useful for you people. Intraoral, it has been divided into, as I told, open mouth and closed mouth. Open mouth, it has been further divided into direct technique, conventional technique. There are certain modification of these techniques which include Charles and Hopkins modification and then Angelino-Sargentini modification. So direct thrust technique, which includes there are certain modifications of it. It's called Boris-Level technique and then Bonnelly technique. In direct technique, it includes modification Fisher 1, 2, 3 technique, and there are other techniques like Clark and Holmes technique, anterior ramus technique, curved needle technique, and there are recent technique which includes fixed technique, inferior alveolar nerve block through the retromolar triangle. And the technique specific for pediatric patients, which includes inverted triangle concept, thumb concept by the right, and the lingular technique. So just take a pic of this slide chart. So this, at least this slide, So sometimes if they ask you what are all the recent techniques available for inferior alveolar nerve block, or sometimes they will ask you a question like what is a specific technique for pediatric patients. So then sometimes they may ask what is called as a right techniques. That's called Townes concept. So I'll tell you a small introduction about in each technique in upcoming slides. Coming back into the slide, a closed mouth technique, which is also called Vazirani Akinosi technique. And then external technique, you just only one technique called as a Kurt Thoma technique. So we'll see half of this in this class and part of that remaining in the upcoming classes. Coming to the inferior alveolar nerve block, the nerve which is anesthetized, you should know it, everyone knows it. It's called inferior alveolar nerve, incisor nerve, mental nerve, and the lingual nerve. Area anesthetized will be a body of mandible, inferior portion of the ramus of the mandible, mandibular teeth, mucous membrane, and underlying tissues anterior to the first mandibular molar. Anatomical landmarks which includes mucobuccal fold, anterior border of the ramus of mandible, external oblique ridge, retromolar triangle, coronoid notch, internal oblique ridge, pterygomandibular ligament, buccal sucking pad, pterygomandibular space. Coming to the indications, the procedures on a multiple mandibular teeth in a one quadrant, then a buccal soft tissue anesthesia anterior to the mental foramen is necessary, then a lingual soft tissue anesthesia is necessary. Coming to the needle pathway during insertion, the needle passes through the mucosa, thin part of the buccinata muscle, loose connective tissue, and a variable amount of the fat. Area of insertion, it includes mucous membrane of mandibular ramus at the intersection of two lines, one horizontal representing the height of the injection, another vertical which representing the anterior posterior plane of the injections. Sorry for the mistake, it's a plane, it's not a pair, it's anterior posterior plane of the injection. Posterior aspiration is 10 to 15 percentage. Coming to the what are all the approximating structures when a needle is in position. It includes, so this is a simple picture, so you can able to correlate the wordings and the picture, so that will be very useful for you people. Anteriorly, you will have a pterygomandibular raphe. Posteriorly, you will have a parotid gland. So this is a parotid gland. Laterally, you will have an ascending ramus of the mandible. Medially, you will have a medial pterygoid muscle. And then superiorly, you have two ends of the lateral pterygoid muscles. Inferiorly, you will have an attachment of the medial pterygoid muscles. I'll repeat it once again. Just remember, this is one of the most important questions. So, what are all the structures when the needle is in position? It includes anteriorly, it's called pterygomandibular raphe. This is a pterygomandibular raphe. Posteriorly, you will have a parotid gland. Laterally, you will have an ascending order of the ramus of the mandible. So this is the ramus of the mandible. Medially, you will have a medial pterygoid muscle. Superiorly, you will have head of the lateral pterygoid muscles. And inferiorly, you will have an attachment to the medial pterygoid muscles. So this is the picture. It shows the approximating structures. Moving on to the other slides. What are all the alternates if inferior alveolar nerve block is not possible for that patient? So what will be the alternatives? It includes mental nerve block. When you give a mental nerve block, which structure will get anesthetized? The structures will be buccal soft tissue anesthesia anterior to the first molar. Other is the incisor nerve block for a pulpal buccal soft tissue anesthesia of teeth anterior to the mental foramen, which means usually second premolar to the central incisor. Supraperiosteal injection for a pulpal anesthesia of central and the lateral incisors, sometimes the premolar and the molars. Gauguin technique, which includes mandibular nerve block, Vazirani Akinosi technique, which includes they are closed mouth and open mouth technique. Closed mouth is Vazirani Akinosi, and then open mouth is Gauguin technique. Pedial injection of the pulpal anesthesia of any mandibular teeth, and in IO, it's also called in the intraosseous injection for a pulpal and soft tissue anesthesia for any mandibular teeth, but especially molars. Coming into the technique. So still now we have seen that where the nerve will get blocked and what are all the structural will get blocked if you use inferior alveolar nerve block. And we have seen the few alternatives. Now we'll see the technique. Inferior alveolar nerve block, the technique is if the patient is in gentle chair, the head should be positioned so that when the mouth is open, the body of the mandible is parallel to the floor. Remember, it should be parallel to the floor. Operator stands to the right front side of the patient and with the left index finger or thumb palpate the mucobuccal fold. The finger or the thumb is then moved posteriorly until the contact is made with the external oblique ridge of the anterior border of the ramus of the mandible. When the finger or the thumb contacts the ramus of the mandible, it is moved up and down until the greater depth of anterior border of ramus is identified. It should be about so this is the structure. Exactly at the coronoid knot, you are going to inject in the needle. See, from the opposite side. For example, if you are going to extract or doing a procedure in this right side, initially you have to insert the syringe from the left side until you hit the needle to the coronoid notch. It is usually 6 to 10 mm above the occlusal plane. Palpating the fingers move lingually across the retromolar triangle onto the internal oblique ridge. So one finger should be placed intraorally and other fingers should be placed extraorally. From the opposite side, you have to advance the needle until it touches the coronoid notch. Once it contacts the coronoid notch, you just aspirate and then slowly inject into that region and deposit local anesthesia. So this is what this sentence states. A finger or the thumb still in the line with coronoid notch and in contact with internal oblique ridge. It's moved to the buccal side and taking with the buccal sucking patch. It's nothing but you are going to retract the buccal mucosa. This gives a better exposure to the internal oblique ridge, the pterygomandibular raphe and the pterygotemporal depression. In palpating the intraoral landmarks with the thumb, the operator may place the index fingers extraorally. As I told, that one finger of thumb should be placed intraorally, the remaining finger should be placed behind the ramus of the mandible. Thus it's literally it's like you're holding the mandible between the thumb and the index fingers. I hope you can able to imagine that as of you're holding the mandible, since the thumb should be placed intraorally and the remaining index finger should be placed extraorally or behind the ramus of the mandible. Literally, yeah, just holding the mandible. As I'm repeating it, it's between the thumb and the index finger. In this manner, the anterior-posterior width of the ramus may be assessed. A syringe with the 25 gauge needle is then inserted parallel to the occlusal plane, as I told in the previous slide, from the opposite side, and it should be bisecting the finger or thumbnail, penetrating into the tissue of pterygotemporal depression and entering the pterygomandibular space. So as I told, this is a picture which shows that how to orient the needle towards the coronoid notch, and it should be placed 6 to 8 mm above the occlusal plane. One can best determine the depth of the needle penetration by estimating when the tip has been advanced half the distance between the palpating left thumb and index finger. During the insertion, the patient is asked to keep the mouth wide open. The needle is penetrated into the tissue until it gently contacting the bone on the internal surface. This should be in the area of mandibular sulcus, which funnels into the foramen. The needle is withdrawn about 1 mm, and remember, aspiration should be done in 2 plane. Once you have been aspirated, slowly deposit 1.5 ml of solution. Once you have deposited the solution, withdraw the needle slowly. Then about 1/2 of its inserted depth has been withdrawn. The remainder of the solution is injected in the area to be anesthetized the lingual nerve. This is nothing but from the opposite side, you are going to contact the pterygomandibular space, inject, deposit the solution. Once you have been deposited the solution, change the needle direction towards the ipsilateral side. That means that the side where you are going to do the procedure, the same side you have to move the syringe. Once you have moved the syringe, just deposit and then block the lingual nerve. In many instances, the deliberate injection of anesthetic solution into anesthetize the lingual nerve is unnecessary because of diffusion of initial injected solution will also anesthetize the lingual nerve. This states that sometimes it doesn't require the lingual nerve block as a separate part, because the first part, as I told, you are going to advance the needle from the opposite side. This itself is sufficient to produce the lingual anesthesia. So that is in some article they have stated this. So this is again the pictorial representation shows that and how to inject the inferior alveolar nerve. What are the subjects? So as I told, there are 2 types of symptoms, subjective and objective. Subjective is what the patient feels. The patient will have a tingling or numbness of the lower lip indicating the anesthesia of mental nerve, or the tongue indicating the anesthesia of lingual nerve. Objective is that what you are going to elicit. Instrumentation necessary to demonstrate the absence of the pen. What are all the possible factors which affect the relative position of mandibular foramen? They are width of the ascending ramus, width of the arch of mandible, obliquity of the angle of mandible. Coming to the anatomical variations, sometimes after you have injected the solution or deposited solution in that region, you will feel the failure of anesthesia. This because of this anatomical variation of the mandible. What are all the anatomical variation? In children, mandibular foramen in 4 years children or in death is below the plane of occlusion. The foramen moves superiorly in the ramus with erection of molars. Sometimes some will have bifid inferior alveolar nerve is detected on the radiograph and incomplete anesthesia may develop if you have a bifid inferior alveolar nerve. What are all the possible complications that should know? It includes emetema, trismus, and the transient facial paralysis. This because if you inject the needle, sometimes you may damage the fibers of the masticatory muscle which is located in that region. Thus, will result in shrinkage and the contraction will result in trismus. Coming into the various other technique, what I have told in the previous slide, I'm just going to go through that technique for you people. Methods of Clark and the Holmes technique. This involves depositing a solution. Only difference between the other technique and the inferior alveolar, basic inferior alveolar technique and the methods of Clark and Holmes is that you have to deposit the solution at higher level than usual, and it's one of the modification of indirect technique. In the standard technique, the solution is placed immediately behind the foramen, which is approximately 1 centimeter above the occlusal plane of molar teeth. At this level, the anterior part of the knee nerve is concealed. Sometimes when you are injecting, the anterior part of the nerve is concealed by lingula and the sphenomandibular ligament. So the local anesthetic solution will not reach as much of the fibers. So when you deposit solution at the higher level, you can avoid this problem. So for that only they are modified and brought this technique called as Clark and Holmes technique. So this is a technique. The index finger is placed in the retromalar fossa and the syringe is advanced from the opposite side premolar. The needle is inserted until the bone is contacted. The syringe is then swung around until it lies over the lower central incisor. The needle is passed another 2 cm deeper inside and the solution is deposited. At this point, the anesthetic solution will have injected more than 1 cm higher than usual. So it is very difficult for you to remember everything. Just remember 1 cm higher than the usual technique that is called as Clark and Holmes technique. Coming to the methods of Ancleo-Sargentini technique, this is one of the modification of direct technique. The principal difference is that the nerve is approached from the similar to that of Clark and Holmes, higher than the usual level. So remember that. So this picture shows that it should be usually placed 1 cm higher than that of the normal level. Coming to the Charles and Hopkins techniques. This is a technique where a perpendicular to ramus with a barrel in respect to the opposite side of first and second molar. Height is above the fingernail, insert directly into the sulcus. So just remember there is another technique called as direct technique of Charles and Hopkins, where the barrel has to be placed from the opposite sides perpendicular to ramus in between first and second molar. Just remember that alone. Coming to the Mendel Nevin technique, this is called as guide corona. Like this is one of the direct thrust techniques. So just remember, sometimes they may ask you who gave this direct thrust technique. So to show that I have put this slide, direct thrust technique has been given by Dr. Mendel and Nevin. Remember that alone. And few advantages are: one, injection provides a wide area of anesthesia. Disadvantages similar to that of the other techniques. Intraoral landmarks are not consistently reliable. Aspiration of positive aspiration is high. Lingual and the lower lip anesthesia sometimes produce discomfort to the patient. Coming to the Brownlee's direct thrust technique. The Brownlee's direct thrust technique is that, so one of the important landmark is, remember, posterior border of ramus of mandible. Remaining everything are the same. Thumb should be placed along the coronary notch. Index should be placed along the posterior border of ramus. Third finger should be along the angle of mandible. So this is like every technique, one above the other technique, everything are the same. Only we will have a few differences between those and few advantages of the dose and few modifications of the dose. So remember the name alone, because like this is the PG aspect of view. So I have put this slide because sometimes in need questions they will ask what are all the direct thrust technique available for the mandibular nerve block. At least you should know the name of it. That's why I put this slide. The direct thrust technique includes Mendel and Levin, and then Brownlee's technique. Coming to the Boris-Levitt technique, it is nothing but modification of Mendel technique. Remember, it's a modification of Mendel technique. There are other techniques called arched curved needle technique. Remember, in arched curved needle technique, the flexibility of fine bore needle is utilized because like finer the needle, once you have bent the needle, it will not get crack, break. Insert at acute angle, the subsequent arching changes the path and the needle approaches the medial surface of ramus almost perpendicularly, which is otherwise impossible to achieve. So because like it is impossible to achieve with that of unbent needle, to overcome that, they have been modifying this technique that's called curved needle technique. Sometimes you may get a picture-based question stating that this picture illustrates what? It's called curved needle technique. And another technique, anterior ramus technique. So remember, there is another technique which is called anterramus technique, where anterior border of ramus is palpated, coronoid notch is identified with the thumb, middle finger and thumb is used to determine the width of ramus, average width of ramus including thickness of soft tissue is 35 mm. Inject the needle until you palpate the coronoid notch. Syringe and the needle at this stage are buccal to posterior molar. The thumb is used to guide the needle as it advances to the medial posterior direction. Inserting half of the length of needle and the needle is turned approximately 30-degree horizontal plane so that the syringe now rests on anterior teeth. End of the needle should now lie medially and in proximity to inferior alveolar nerve as it begins to enter the foramen. So it should sit slightly superior and medial to the foramen. So as of now, we have seen different techniques. I know this, they are all very different and new to you people. So just remember those few lines. I'll repeat it again. There is a method called Clark and Holmes where there is a modification of direct technique where you are going to deposit the solution 1 centimeter above the occlusal plane. Coming into the Angelino Sargentini technique given in the year 1966 as a modification of direct technique, it's similar to that of the indirect technique modification where you are going to deposit the solution higher level than the usual. There is another technique called direct technique of Charles Hopkins. This is one of the technique where you are going to advance a needle from opposite side between second and first molar, similar to that of the standard technique, but they are given few names of it. Direct thrust technique given by Mendel and Levin, and there is another direct thrust technique called Brownlee's technique. And the modification of Mendelian technique is called as Boris and Levitt technique. Remember, they will never ask you in detail about the techniques in a questions, MCQ based question. Only they will ask you what is the modification of Mendel's technique. So you have to remember it's a Boris and Levitt technique. There is another technique called arch and curved needle technique and anterior ramus technique. Remember, arch and curved needle technique, they have introduced it because inserted at acute angle, the subsequent arching changes the path and the needle approaches the medial surface of ramus almost perpendicularly. So this is not possible with the help of the unarched needle. Remember that alone. And there is another technique called anterior ramus technique. Coming into the main part is there is an indirect technique. I hope if we are using this technique called Fisher's 1, 2, 3 technique. What are the Fisher's 1, 2, 3 technique? Step 1, you are going to anesthetize the buccal nerve. Step 2, you are going to anesthetize the lingual nerve. I'm not going in detail because I don't want to confuse you people. Remember the points which is needed for your MCQs. In step 1, you are going to anesthetize the buccal nerve. In step 2, you are going to anesthetize the lingual nerve. In step 3, you are going to anesthetize the inferior alveolar nerve. In step 1, the needle is advanced up to 6 mm. Remember, the needle is advanced up to 6 mm. In step 2, like 6 mm, you have already advanced the needle. In addition to the 6 mm, 8 mm, you are going to further advance the needle. So totally, until the step 2, we have advanced 8 plus 6. is equal to 14 mm. We have inserted the needle into the soft tissue. Remember, in step 1, you are going to advance the needle to 6 mm. Until 6 mm, the needle will be inside the tissue. And the step and you have deposited the solution and you have anesthetized the buccal nerve. In step 2, you are going to further advance the needle to 8 mm. So already 6 mm plus 8 mm, so totally 14 mm of needle is inserted inside the soft tissue. In this step 2, you will block the lingual nerve. In step 3, you are going to further advance a needle of 12 to 15 mm. So totally there are absolutely 25 to 26 mm of needle is inserted inside the tissue. In third step, you are going to block inferior dental nerve. So these are most important questions in a indirect technique given by a Fisher. 1, 2, 3 technique. In the first technique, you are going to block a long buccal nerve. In the second technique, you are going to block a lingual nerve. In third technique, you are going to block an inferior nerve. In step 1, the needle is advanced in 6 mm. Step 2, a needle is advanced to further 8 mm. Step 3, the needle is advanced further 12 to 15 mm. Coming into the closed mouth technique, which is called as Vazirani Akinosi technique. The nerve which is anesthetized will be inferior alveolar nerve. Area anesthetized will be all mandibular hard and soft tissues to the midline, including the floor of mouth and anterior two-thirds of tongue. Anatomical landmark. See, this is a picture shows that anatomical landmark in detail. Occlusal plane of the occluding teeth, mucogingival junction of maxillary molar, anterior border of the rambus of the mandible, and the coronoid notch. Indicated when the patient is having trismus and multiple posture on mandibular teeth, inability to visualize the landmark. Advantages: relatively atraumatic. Patient need not to able to open the mouth because this is closed mouth technique, doesn't require opening of the mouth. There are only fewer post-operative complications. Aspiration rate is very low. The disadvantages is that difficult to visualize the path of the needle because as the patient is closed his mouth, it's very difficult to visualize the path. No bony contact, so depth of penetration is arbitrary. You cannot able to predict how much of the depth of needle has been inserted. Potentially traumatic if the needle is very close to periosteum. Needle pathway during insertion is with the mouth closed, the needle is aligned parallel to the occlusal plane and positioned at the level of mucogingival junction of maxillary molars. The needle is penetrated mucosa just medial to the ramus and is inserted approximately 1.5 inches. Coming into the approximating structures when the needle is in positions, they are inferior alveolar vessels, nerve. This is a picture shows that inferior alveolar nerve, vessels, lingual nerve, buccinata muscle, mylohyoid muscles, mylohyoid nerve, and anterior to deep part of parotid gland, medial surface of the ramus of the mandible, internal pterygoid muscles, sphenomandibular ligament. So remember the picture. And how to give the closed mouth technique. So how to proceed with that? It includes with the patient seated in dental chair, the operator stands to the patient right side and slightly to the front. Patient is instructed to occlude the teeth, which means the patient has to bite in the chewing position. So this picture shows that the patient is in chewing position or occluded the teeth. Operator retracts the patient lip, exposing the maxillary teeth and the mandibular teeth on the right side. The syringe is aligned parallel to the, this is occlusal plane. You are going to align the syringe parallel to the occlusal plane at the level of mucogingival junction and slowly penetrate the needle medial to the ramus approximating 1.5 inches. Do aspiration in true plane. Whenever there is a negative aspiration, slowly deposit the solution. After injection, return the patient to the upright or semi-upright position. Motor nerve paralysis develops as quickly as or more quickly than a sensory anesthesia. Patient with the trismus begins to notice increased ability to open the jaw shortly after the deposition. Successful anesthesia will be determined by instrumentation of inferior alveolar nerve. So this is the technique of an inferior alveolar nerve. So as of now, we have seen there are various types of intraoral and extraoral technique, and we have seen a slide that showing that what are all the intraoral techniques and modification available in it. And we have seen what are the open mouth technique and few names for the open mouth techniques modification. And we have seen the most important topic is fissures 1 to 3. There, one in step 1, you're going to anesthetize long buccal nerve. In step 2, you're going to anesthetize the lingual nerve. In step 3, you're going to anesthetize the infraalveolar nerve. Step 1, 6 mm of advancement. Step 2, further 8 mm of advancement of needle. In step 3, 12 mm of advancement of needle. And we have seen Clark Holmes, anterior ramus, curve needle technique, and then we have seen the closed mouth technique, which is called as Bazirani Akinosi technique, indication and advantages and disadvantages of it. Upcoming class, we will see the remaining techniques. I hope you people have learned something new, because like this is I've searched few articles and I've collected the details, because sometimes they'll ask you a question. I don't want you to lose a single mark in this mandibular nerve block technique. That's why I added a few extra slides and few extra names for you. Just remember the names alone. That will be enough for you people. Thank you.